ആ ഇതിൽ തന്നെ ഉണ്ടാവും. ഫോണിൽ വിളിച്ചാൽ കിട്ടില്ല. ഇതിൽ തന്നെ സ്റ്റാർട്ട് ചെയ്യാൻ പറഞ്ഞാ മതി. ഫോൺ എന്തോ സ്റ്റക്ക് ആയി പോയി. അതാണ് നേരത്തെ അത് ഇതാക്കാൻ പറ്റുന്നത്. സംറ അല്ല, എനിക്ക് സ്ലൈഡ് ഷോ വരുന്നുണ്ടോ? നിങ്ങടെ ആ യൂട്യൂബ് ആ, ഓക്കെ. Good evening, all. So I think all of you are on their final preparation for the exam that is coming soon, and your theory exam is coming. All of you might have prepared well. I'm just as the college union asked me to take a class on the common essays, and they have suggested two topics to me. I will be covering that. And before that, I will think a brief introduction to the pediatrics exam also. So you are the 2019 joining batch. You are the first CBM batch with the new curriculum. So there are some difference in teaching and the assessment also different. So your questions differ a little bit from the previous batches. So all of you might have underwent that your model exams. Just to revive, what is the theory pattern as per the Kuhas? The Kuhas theory you have previously we had 40 marks. Now it is the 100 marks for your batch. So essay you will have two essays, long essays. These two will be clinical scenario based questions. That is to know how much you know about a subject. You cannot just mug a topic and write. You have to analyze. A clinical scenario will be given. You have to give the answers for the questions. So the most important thing, you have to identify what is the scenario and then answer. If you could not identify the scenario, you will be losing marks. So after that two questions will be there. After that, there are short essays. That is 5 short essays of 8 marks duration of each. This will be based on mainly clinical features or management of common clinical cases. This will be in the 8-mark questions. After that, you have short answers of 4 marks, 5 questions. This will be concentrating on general pediatrics like growth, development, immunization, nutrition, and neonatology. And they may ask some diagrams as a part or the full question. Previously, there were two previous question papers. There are 2 draw and label. Now here you may get a diagram in this part. So be familiar with the common diagrams in your OPGI or standard textbook also. After that, you will have, presently we are having 10 precise answers. That is not a multiple choice, but one word or one sentence answers. It will be covering all the variety of things what are not covered. Some from pediatric surgery, basic science topics. It is NMC has told that your basic science topic should be included in your final year exam. Some lab investigation, embryology, genetics, all the things will be covered, and emphasis on national programs. 50% of questions should be from these parts in this last 10. And there is in coming years, it may be replaced by 20 marks MCQ. That is the new guidelines. But presently, I think this year you will be having this precise answers only. And as a general instruction, you will getting a 4 marks out of 8 com. You had studied your 8 com from your first year onwards, and 4 marks will be dedicated to 8 com question in the theory paper also. And of the total 100, 15%, that is 15 marks for the neonatology questions. That also you have to give importance to neonatology as well. There's some general instruction, and one thing, even in this format, they have mentioned that the competencies in the curriculum. So if you have time, just go through the NMC website and you will get the volume 2, your curriculum. These competencies are given there. Actually, we are supposed to put questions from this competency only. That is the ideal thing. You will get questions from any of the competencies, especially that is mentioned as Y, that is core competencies. That just go through whether you have covered all these questions, you can just go through it. So now coming to what is today's discussion, I am asked to discuss long essays, because long essays you have 30%, and if you can get the diagnosis, you can score marks, but if it goes wrong, you may miss. So there are some these are the some probable areas in pediatrics you can get long essays. There are several other areas may get, but commonly they ask questions from these areas, which are very important for a pediatrician. So if I'm starting from the general pediatrics, a child with a short stature, you can have a question on short stature, development delay scenario can be asked. And very, very common, these red things are very commonly asked essay questions. Child with a severe acute malnutrition, this clinical features, management, the 10 steps, all these are very commonly asked. You may be given the anthropometric parameters, danger signs, you have to classify that all. And obesity in children usually not asked, but it is given in your competencies. Iron deficiency anemia, very commonly asked topic. Be familiar, it is the basic thing. So it related to your nutrition. This is very important. Learn completely about iron deficiency anemia. Then the renal system, you can have scenarios of acute glomerulonephritis or nephrotic syndrome. Occasionally urinary tract infection also. Acute glomerulonephritis and nephrotic syndrome are usually kept for case discussion also. So try to differentiate these two. Only then you can answer correctly. May have a question from rheumatic fever scenario. A cyanotic congenital heart disease commonly when with the CCF. Then diarrhea. Diarrhea is also very commonly asked question. May ask viral hepatitis, acute respiratory tract infection, ARA control program related management of pneumonia or bronchiolitis or asthma. These scenarios, you have to identify what is the diagnosis, what are the differential diagnosis, management, clinical features, everything will be asked. And hemolytic anemia, commonly hereditary serocytosis scenario, thalassemia may be asked. And related to hematology, you can get questions related to ITP. This immune thrombocytopenic purpura can be a discussion. Is always, it may coincide with your malignancy. This differential diagnosis may be very insane. Then can have infections like meningitis or encephalitis. You can have questions, meningitis, encephalitis, TBM. Then tuberculosis, dengue is a common problem in our area. You can get question on dengue also, measles as well. These are the some probable areas where you have to concentrate for getting an essay question. So actually they asked me to include some top essays in cardiovascular system and hematological malignancy. I'm discussing a hematological malignancy. As of your new curriculum is concerned, there is not, it is not a very core area for you, but you should have a basal idea about this hematological malignancy also. So whenever you are answering, be specific to the point. Don't the unnecessary things and waste your time. The examiners also will be very busy when the evaluation, and neatly don't give adequate space, and your answer sheet will be scanned and we will be evaluating in the computer. So when the scanning, you have to use good pen so that your handwriting is legible for us in the computer screen also. And this neatness, this will add on to your marks. Then don't write some things. You may have some doubt. If you write a wrong answer and the other parts of the answer is correct, you may not get the full mark because you have done a great mistake that is actually should not be done for that patient. So some such mistakes may decrease your marks even though you have included all other points. Like whenever you are asked to write the investigation, there is a tendency to write everything, CBC, LFT, RFT things. Don't write indiscriminately. you have to think and write. Actually, when sometimes you may have a case of febrile seizure. In all febrile seizures, there is no need to take an MRI, CT, and all. So you have to usually what we find in the exam, you are writing all the investigation what you know. For even all the acute glomerulonephritis, nephrotic syndrome, you may be writing biopsy in all cases. That actually decrease your mass. And also regarding the drugs, it is well if you know the drug dose, duration, and all, write it properly. That is will add on your mark. But if you don't know the dose, don't write something wrong dose. Wrong dose may actually decrease your mark. And actually, as far as possible, try to explain your concept with a flow charts or some diagram that may very easy for us to evaluate, and you may get more marks. So these common things you can use. And actually, when you are writing, sometimes you may need to skip some of the questions you don't know properly, that you may be writing last. But as far as possible, try to follow the order that may be more convenient for evaluation. There is nothing that you have to follow the strict order. As far as possible, try to the order. If you don't that you can, one or two questions you can write in the end. That will be more full. That is, maybe you may get more marks. So I will be discussing 2 essays. Anything to be explained so far? Anything clarification or needed? So I will be continuing. So the one essay I am going to discuss, just you can watch this. Here it is usually it's a scenario based things. You have to, it's maybe a little bit long. I think you are familiar with the scenario based questions from their first year onwards. Here it is a 2-month-old infant brought with cough. Hello? ഇട്ടിട്ടുണ്ട്. ഇതൊന്നും വരുന്നില്ല. ഇതുവരെ ഒന്നും. അതെ. അല്ല, ഞാൻ നേരത്തെ തന്നെ സ്ലൈഡ് ഷോയിലാണ് ഇതുവരെ പോയിക്കൊണ്ടിരുന്നത്. അല്ല, ഇനിയിപ്പം അതാണ്. അല്ല, എനിക്കാണെങ്കിൽ ഞാൻ അതിലെ ചില അനിമേഷൻ ഒക്കെ വരുമ്പം അതാകുമ്പോ കിട്ടില്ല. ഓക്കെ. അപ്പൊ ഇതുവരെ ഉള്ളതൊന്നും കണ്ടിട്ടില്ല അല്ലേ? ഓക്കെ. ഓ, ഞാൻ ആ ഒരു ക്വസ്റ്റ്യൻസും ഒക്കെ ജസ്റ്റ് കുറച്ചെണ്ണം ഇട്ടിട്ടുണ്ടായിരുന്നു. അതൊന്നും any need to go back? Whether we need to go back anything? So actually, first case is a 2-month-old infant is brought with cough and breathlessness for 1 week. The birth weight was 3 kilo and the present is 3.3. On exclusive breastfeeding, mother noticed interrupted feeding and excessive head sweating for last 2 weeks. On examination, heart rate 148, respiratory rate 62, febrile, SpO2 99% in room air. Apex beat was palpated at 6th left intercostal side outside midclavicular line, and there is a pansystolic murmur of left sternal border. Actually, you may get a history. There may not be, all the findings may not be given, but some points that help you to make a diagnosis will be given. So here you have 50 marks question. So it is what is the most probable diagnosis? Write 4 points in the history and examination favor you are telling this diagnosis. Mention 4 other clinical finding you expect, and list 3 investigation you will order with the expected findings, and discuss the management. The marks may vary depending upon the importance of the question. Are you seeing this question slide now? Okay. So when you are discussing the case, so you can see the here what is the probable diagnosis. There's a tendency that you may write ventricular septal defect, but actually it is a correct answer, but it is not a complete answer. Try to write the complete answer. Here you have to write as cyanotic congenital heart disease. That is not a must. Moderate to large ventricular septal defect. You have to specify that, because ventricular septal defect can vary in severity in presenting as congestive cardiac failure. Most of the manifestations are due to congestive cardiac failure. Here the full answer will be moderate to large ventricular septal defect in congestive cardiac failure. So you may be thinking you are right VSD writing alone, but you may not get the full mark there. What are the here DDs were not asked. The one DD you can mention here is one thing is a patent ductus arteriosus. That also, if there is a significant large size, you can get similar findings like this failure to thrive, interrupted feeding, head sweating, feeding difficulty. All the things can occur. The only change is what is the findings you get here. Even in a PDA, sometimes you may get a systolic murmur alone instead of this a continuous murmur in the upper sternal border. So the close differential diagnosis can be patent ductus arteriosus. So if they have asked for a DD, so the diagnosis part, there is only one mark, but you have to write completely. So next point is 4 points in history and examination favoring the diagnosis. Here in the history, 1 point, why you are telling this diagnosis. There you have to be specific age of the child. You should know that a hemodynamically significant VSD PDA, the cyanotic congenital heart diseases post-tricuspid shunt, presents at 6 to 10 weeks of life. So this presentation age is very important for making the diagnosis. Then history of interrupted feeding, because for a child in this age group, the most important work child is doing is feeding, and during feeding there is it is equivalent to the exertional dyspnea, and there is an increased sympathetic activity that you can have as head sweating, and these are not the features of VSD, but these are the features suggestive of congestive cardiac failure. And you can see only 300-gram weight gain during this period. That indicates usually during this period, child should gain 30 gram per day. So this weight gain is inadequate. Failure to gain weight also indicates child is having a congestive cardiac failure. And cough and breathlessness can be due to the lung congestion as a part of this CCF and VSD. So all the cough and breathlessness need not be due to respiratory cause, but at the same age you can have a bronchiolitis presenting at this age. So one DD you have to consider in mind is a bronchiolitis, usually in a child, but here you have other features also. So the examination, the points favoring your congestive cardiac failure is tachycardia and tachypnea are the two important signs of congestive cardiac failure in an infancy, and that favors. And also your saturation is 99, that means there is no cyanosis. And examination, there is cardiomegaly, and your typical pansystolic murmur in the left sternal border shows that this child is having a VSD with a VSD. So these are the examination findings. There may be more than 4, but you have to include the most important features why you are telling this diagnosis. All the findings are not mentioned. So the next question is, what are the other findings you can expect? Include tender hepatomegaly. Tender hepatomegaly is considered as the most consistent sign of congestive cardiac failure in infants and children, and you have to look for that. And you may get a bilateral crepitation due to this pulmonary congestion as a part of CCF. And on palpation, you can have a hyperkinetic precordium. And regarding the heart sound, when on auscultation, the second heart sound is the split is very important. You may be remembering the NADA's criteria, which is useful for this diagnosis of a congenital heart disease. Then also second sound is very important. The split can be wide and variable because the aorta empties very fast and the pulmonary valve closes very late, but there is a variation with respiration still persisting. And when there is a pulmonary artery hypertension, you can have a loud P2 also. As our child, we are expecting a moderate to large VST with a significant shunt. There can be a delayed diastolic murmur that can be heard, or also can be a S3. These are the findings you are expected. Though you expect an ejection systolic murmur and pulmonary area, that cannot be made out due to this pan-systolic murmur. So these are some clinical findings that you expect other than what is given in the question. So investigation, what you will order and the expected. If you are asked the 3 investigation for this child, you go on the investigation that will help you to make a diagnosis. Don't write everything. Here the most important for your diagnosis is you can take an ECG that can show a left ventricular hypertrophy, or if there's a severe case, you may get a biventricular hypertrophy also, which is known as Katz-Wachtel phenomenon. That is both this ventricle, they were for your level it is enough. Then the X-ray chest, you can have a pulmonary plethora. The vascularity in the X-ray extend to the lateral third also, and there can be cardiomegaly with the left ventricular type apex. The definite diagnosis is done with using an echo. You can identify what is the size of the shunt, site of the shunt, type of the shunt, and also if a Doppler can help to assess the pressure gradient. These are the investigations you can make for the diagnosis. If you are asked to do a more investigation, what are the things? You can do a complete blood count, the hemoglobin. You have to assess if there is an anemia. That is will be more important little bit older child, because if there is an anemia in a child with congestive cardiac failure, you correct that anemia as a part. So that hemoglobin part may be more useful. Then is all the cardiac cases, when you are managing, you may be using some drugs that can have a renal clearance or can affect on kidneys. So a renal function test and electrolytes may help. There is no need for much investigation other than this. Don't write every investigation for all children. Whatever you heard, that is of no use. So discuss the management of this. Management has the maximum marks. So you have to categorize these symptoms. How can categorize as what is the child with VSD in congestive cardiac failure. You have that idea. Then you have to decide what is the management of congestive cardiac failure, then management of the specific cardiac condition. And as it's a pediatrics, whenever you have to give importance to the immunization part, nutrition part and all, and you need to treat infection if occurring in between. So in cardiac failure, how we are going to manage? I think most of you are following your OPGAI as your standard textbook. They have given the 4-prong approach. One important thing is the reducing cardiac work. How you will reduce cardiac work is head end elevation, that will decrease, that will give some relief to the child, temperature control, oxygen inhalation, sedation, if the child is very much irritable, and if correct anemia. And you may use an AC inhibitors. It will this angiotensin converting enzyme that will reduce the peripheral vasoconstriction, so the work of heart is reduced, and it will also decrease the salt and water retention. So it may reduce the work of heart. So these points, some of these points you have to include. And then the other thing is, now you decrease the work, you are increasing the myocardial contractility. The time previously we are very much depending upon the digoxin, what was concerned as first drug, but now its importance is decreasing. So you can write, still write it as it is given in your book and all, and still we are using digoxin. And in an acute condition you may use more these inotropic drugs like dopamine, dobutamine in an ICU setting for a level, your level, just mentioning these will be sufficient. And there are some agents that is usually in our situation, we are using these drugs as the first care, like reducing the preload by using diuretics, especially furosemide. So these are the main points in the medical, and whether you have to go with a definite management, medical or surgical. Medical management, we mentioned the management of congestive cardiac failure, and as child grows, some of the you have to mention that some of the VSD may decrease in size and may close spontaneously. You can wait for a level of aortic regurgitation due to the prolapse of the cusp, then development of obstructive pulmonary arterial hypertension, pulmonary stenosis, and sometimes even whatever drugs you give, the CCF is not controlled. There is severe failure to thrive, and the child can and child is having recurrent respiratory infection requiring frequent treatment. In such situation, you may go for a surgical treatment. So what are the surgical options available? Also, you have to mention. So these are some indications, and surgical options can be an open heart surgery using a patch closure, and for a small thing, a catheter closure may be done. So following a closure, also you can have some complications like heart block or a residual VSD. Something like what is the medical closure and medical management as well as the surgical option you should know, and look for already mentioned complication like infective and that I have already mentioned in the previous slide. These are the parts of the question what I asked in that question, but there are other questions related to maybe asked in a child with a cardiac issues, like what are the different types of VSDs, that may be asked in a part of your other question, or what is the natural history of the disease. For this congestive cardiac, this VSD, you should know that a significant percent of a large number of small VSDs close by themselves. Only large and moderate and large may require surgical options. That thing is clearly given near OPG that you can ask. And as a other part, you may ask the hemodynamics diagram of this all the heart disease, common things like this VSD, patent ductus, tetralogy of Fallot, all the things may be asked for the diagram as well. So may I go to the next question, or if you have anything related to any doubt related to this, and I don't know what you are expected from me. And actually I am not having this slideshow. There is some difficulty in presenting it. So any doubt or clarification you need? Okay. So second, I think there are so many other important essays, but you may be very familiar as you are saying. So I will discuss another scenario. Here you can see a 4-year-old boy brought with fever of 2 weeks duration. Child seemed to be irritable and wakes up night due to leg pain. On examination, there was severe pallor, generalized lymphadenopathy, and hepatosplenomegaly. Here you can see there is only some points are given, so you can have a wide variety of differential diagnosis also. So the questions, sub-questions are what are the most probable diagnosis with the supporting points for that. You can need to write differential diagnosis you consider, and mention what are the other features you look in this boy. and then what are the investigations and what's the result expected and how you are going to manage. Here, when we analyze each part, probable diagnosis. Here you have a child with prolonged fever, that is 2 weeks fever, nocturnal pain and leg pain, probably that may be a bone pain. The prolonged fever you will get in all this type of hematological malignancies, and hepatosplenomegaly shows an infiltrative disease, and severe pallor, sudden onset severe pallor, and generalized lymphadenopathy, and these all favor a diagnosis of a hematological malignancy, with the most common acute leukemia. Acute lymphoblastic leukemia is the commonest to present with this much lymphadenopathy and hepatosplenomegaly. So you have to, these are the some points in the to favoring the diagnosis. Next, what are the differential diagnosis? Here, always you can consider the differential diagnosis in the form of infection, inflammation, infiltration, and all. But sometimes you need to prioritize which is common. The common infections that can present as hepatosplenomegaly, lymphadenopathy, one can have a prolonged course is an infectious mononucleosis. You have to know details about it. Can present with a fever, sore throat, generalized lymphadenopathy, splenomegaly, and all. So it comes as an important differential diagnosis in hematological malignancies, but unlikely to have a severe pallor or this nocturnal pains. Another condition that can present as a PUO with hepatosplenomegaly, lymphadenopathy and a leg pain is a systemic juvenile rheumatoid arthritis. It should be considered in all children with a prolonged fever. You may get a rash also, but this much severe pallor and a nocturnal pain awakening this child during sleep is less likely to be in a systemic juvenile arthritis. So when you want to consider more differential diagnosis, it can be a disseminated tuberculosis. In our scenario, as tuberculosis is relatively common, and then even a leg pain, but there are some points that are not seen in these conditions. So you have to write what is the most probable diagnosis in these settings. So other specific clinical findings. You can look for bone tenderness. You can press over the sternum or the tibia, where because you are expecting, because this child is having a leg pain, you can get a bone tenderness, and bleeding manifestation is not mentioned about it in the history, but you will get all the three affected in a suspected hematological malignancy. So look for purpura, ecchymosis, oral bleeds, and all. That will favor your diagnosis of a leukemia. As it's a male child, testicular involvement can occur in acute leukemia. So you can look for the any testicular swelling, and others can a mediastinal mass. You can percuss over some features of superior vena cava syndrome can occur. So some puffiness of the face and engorged neck veins, all these things may be seen. So next, coming to the what are the investigation will you do in this child and what are the expected results. This in the so here also try to be specific. And if you are writing CBC alone, you have to mention what you are writing. Complete blood count, you can find out knowing the anemia that has an implication in the management whether the child required transfusion. In total count, most commonly you will get a leukocytosis, but occasionally you can get leukopenia also, and the differential count usually it is lymphocytic. But if it is an acute myeloid leukemia, you may have others, but in that time, in a myeloid type, you don't get this much lymphadenopathy. And platelet, you can look for thrombocytopenia, that is usually there. And very high ESR usually suggest a malignancy or connective tissue disorder. More than more than 100, usually you won't get an infection. That more than 100 millimeter in the end of first hour, you may have to think in terms of malignancy or an inflammatory condition than an infection. Then next investigation is peripheral smear, that is very easily available. It can diagnose, it can look for blast, and you may diagnose thrombocytopenia with this smear itself. That is the first clue for diagnosis. So if you have a clinical clue, you are confirming the diagnosis is with bone marrow aspiration or in sometimes biopsy. In the bone marrow aspiration specimen, you can write just you will look for the morphology of the cells, and in the present era, we will do flow cytometry for immunophenotypic classification like pre-B cell, all this type, T cell, T lymphocytic, all these things you have to can do, and cytogenetics also can be done for that has a prognosis, and it will affect the what will decide what's the therapy you are planning to do. So CBC, our peripheral smear, bone marrow, and then if you are having such a lymphadenopathy and all, there's a condition, complication of hematological malignancy you have, that's a tumor lysis syndrome. There you can look the serum electrolytes, like they can present as hyperkalemia, hypocalcemia, hyperphosphatemia, hyperuricemia. And so these values can be looked after. And an X-ray chest is very important to look for any mediastinal mass. It can cause a compression and respiratory distress that needs emergency management. And all cases, you need to do a CSF study to rule out CNS involvement. At the same time, we initiate the CNS preventive therapy as well. So these are some specific investigation. Don't write LFT, RFT alone for these all the things. If you know, be specific. Then how your management. This management of your hematological malignancy is a wide thing, and it's mainly managed with oncologists. That is, I mentioned that these are mainly not a must competency for your at your level. So the supported, we have to say that what's the generalized treatment options. Here the supportive treatment, you have to prevent and treat infection, that have to be given very important. Blood component therapy like packed red cell transfusion and this or platelet transfusion as and when required is very important in this therapy management. And if they are having severe pain, consider that also, and proper nutrition, and sometimes these children may need psychological support. Even a hair loss may affect their psychological aspects, and you have to give proper support. And the treatment is long duration, up to 2 to 3 years, so ensuring compliance is also very important. So this is the supportive treatment of part is equally important to the definitive treatment, but we have to the definite management of this condition, where the chemotherapy comes is mainly for acute childhood lymphoblastic leukemia. It is the chemotherapy. 24 to 30 month duration treatment is needed, and it is divided into 4 phases. That is induction of remission with using the drugs. If just know the names of the drugs like prednisolone, vincristine, L-asparaginase, this anthracycline type drugs. Then you have to give the CNS preventive therapy, because these are considered as some sites where you may, the testis and CNS are considered where you can have the relapse. So we give intrathecal methotrexate. In high risk may go for an irradiation also. And depending upon the risk, you may give a consolidation, intensification of therapy with high dose methotrexate, cyclophosphamide, and all. Then need a long-term maintenance of to more than 2 years with daily 6 mercaptopurine and weekly methotrexate. These are the, just you mentioned about some chemotherapy is the treatment and what are the phases. At your level, no need of explaining in details, but you should have a basic idea. And what is the role of stem cell transplantation as a primary option? Usually we don't go, only in very high risk cases of some cytogenetic abnormalities may, but then you have to consider in relapse cases. That is the definite treatment you plan for these children. So I have prepared for these two questions. I don't think you will have that much span of time. So I think if we have any clarification needed or any other things, we will do. And also, I think I will go to this some important questions previously that was missed due to the slide sharing issues. So I just these are the question. The previously the slide I think it was shared, but it was not there. This is the pattern of question. You can look like it's a long essay of this 15 into 2 marks, clinical scenario based. Then short essays, 8 marks, 5 question. Then short answers. You can get neonatology question and other basic pediatric questions. May get a diagram, then answer precisely in covering all other topic, including pediatric surgery, national programs, and your basic science topic. Have 4 mark question from 8Com and 15% mark from neonatology. Study this, all the competencies, just go through whether you have studied. And actually I want to show this slide because these are the some common cases that can kept for the exam. You may note down because you are all have studied about all these cases, and or as all of you have seen cases, has taken cases, it will be very easy for you to write the case scenario based essays. എന്തെങ്കിലും എനിക്കാരെയും കാണാൻ പറ്റില്ലല്ലോ, അപ്പൊ എന്തെങ്കിലും ഡൗട്ടോ എന്തെങ്കിലും? ഓക്കെ.